Good afternoon, everyone. I'm going to go ahead and get us started and with a couple welcoming comments. My name is Nicole Bell. I'm the Executive Director of the Cambia Grove. Thanks so much for joining us this lovely afternoon. I think you made the sunshine with this event, and we're really grateful. We're also grateful to have this event number 2 in a series of 3. Talk loud enough, but we've got a live stream going, so I want to make sure they can hear us too. In 3 weeks is our culminating event of this topical series. For those of you who have not been to the Cambia Grove before, and I see so many familiar faces, so I suspect most of you have been here. So we are a healthcare industry-focused innovation hub whose mission is to convene and catalyze healthcare innovators and their mission to transform our healthcare system. We have 2 specific things in that mission statement that we care about the most. One is to reorient our healthcare system around people and individuals and their families. And the second thing is to lower the overall cost of care in the ambitions that we drive forward in transformation efforts. And so we exist to support that. And tonight, tackling the topic of social determinants of health is yet another really unique way to bring a different kind of topic to the innovation audience and to help see where it goes, and hopefully 1,000 flowers may bloom. So with that, I'm going to hand things over to our moderator, Sam, to get us going, and he can introduce our illustrious panel. And once again, thanks for being here tonight.
Just want to check if, can everyone hear me? Is this good? Sounds good? Okay. I am Samuel Verkhovsky. I am with the Cross-Cultural Healthcare Program. We are a training and consulting organization, and our primary activity is the training of medical interpreters. We also provide cultural competency training, and we have a system, or network rather, of licensed agencies in 26 US states that teach our curriculum. And we have some other customized trainings and patient guides and things like that. Prior to my work at the Cross-Cultural Healthcare Program, I was at Harborview Medical Center for 12 years, and I was a Russian, Ukrainian, and Hebrew medical interpreter. I am very excited about this panel because I approached the Cambia Grove a year ago after I completed my master's degree in something unrelated in international economics. I approached the Cambia Grove and said, I want to do a quarterly panel that will discuss language access and involve collaborators in our community here and get a lively discussion and debate going. So I ended up here somehow, and I'm very happy that we're convening this discussion. So last comment before I ask our panelists to introduce themselves, I'm very glad Nicole said that one of the goals of the Cambia Grove is to reorient the discussion or reorient questions back to the individual patient. And I think that addressing social determinants of care, social determinants of health, is one very effective way to reorient attention and focus back to the individual, because every individual has their own social determinants of health. I would like to ask at this point our panelists to please take turn to introduce yourself and tell us who you represent, where you're from. Please.
Good evening. My name is Kachina Inman. I'm here representing Southwest Washington. So I am the Executive Director of the Healthy Living Collaborative of Southwest Washington. I work in Clark County, Cowlitz County, Skamania, and Wahkiakum. So 4 counties. We're a collaborative, so we work with over 50 organizations across that 4-county area. We're focused on creating healthy communities, and we really do this in 2 distinct ways, really looking at the ability to engage with the community and look at community-based prevention efforts, as well as always keeping our eye on the policy and systems levers. So honored to be here tonight and looking forward to a good discussion.
Thank you, Kachina.
Thanks. My name is Michael McKee, and I'm the Director of Health Services and Community Partnerships at International Community Health Services, which is a federally qualified health center. And there are acronyms for everything that I just said. Because it's a mouthful. The International Community Health Services has been around for about 42, 43 years. We started in the International District in Chinatown and then expanded in the mid-90s to the Holly Park neighborhood in South Seattle, and in 2014, in large part thanks to an improving economy and the Affordable Care Act, expanded to Bellevue and Shoreline. And in between, we've opened up a school-based health center and also have a mobile dental clinic serving 10 Seattle schools and 2 Shoreline schools, as well as community partners during summers and other school breaks. And I'll save some of the other work that we do and who we serve for later.
My name is Rachel Ceballos, and I'm an assistant member at the Fred Hutchinson Cancer Research Center. I'm an assistant professor at the University of Washington. And my work is primarily in the Seattle area, Eastern Washington, and some in New Mexico State as well. I'll talk a little bit more about that later.
Good afternoon. My name is Leanne Miyagawa, and I am assistant nurse manager of a program at Harborview Medical Center called Community House Calls, where we focus on the access of care for immigrant and refugee populations.
Thank you, everyone, for introducing yourselves. And I'd like to next ask you, please, to tell us each which populations you work with and what are the obstacles or the challenges or the hurdles that these populations face in accessing healthcare. In some cases, it's not always healthcare. And if you could start with that, please.
Great. Well, I'm going to go into a little bit more detail about how our collaborative works, because that will help you understand the populations we serve. So for us, I mentioned that we do a lot of community-based prevention and engagement, and to date, that's really been centered around community health workers. So how many of you are familiar with community health workers in the room? So many of you. So really, community health workers are lay public health workers, right? They're often members of the community. They speak the same language. They have similar shared experience. In Southwest Washington, we've trialed something a bit different in that we've looked at creating teams of community health workers. So we started by selecting 3 of our highest need communities in Southwest Washington, one being in central Vancouver, a pretty urban area for us, maybe not urban in comparison to Seattle, but for Southwest Washington, urban. And then South Kelso, which is in Cowlitz County, a little bit more rural, and then Wahkiakum County, Cathlamet, which is a very, very rural community. So we started by selecting the natural helpers, natural leaders living in communities that were really experiencing significant health disparities. And we went through 90 hours of community health worker training together. So we built a team. We built on people's existing skills, knowledge, expertise of their communities. And now they're working in those neighborhoods. So we have a very strong focus in those 3 distinct neighborhoods. So they are volunteers. They are giving a ton of their time and energy. We thank them by giving them a $200 stipend. This was modeled after some work done in Salishan, housing authority in Tacoma. And it's been pretty phenomenal. So they're connecting their family, friends, and neighbors to resources in ways that often as professionals we can't do, right? Because they're next door. They're experiencing the same thing. They were there when the drive-by shooting happened, 3 days earlier, and their kids were in the backyard, right? They were there when the housing complex sold and, people were without homes. So shared experiences. And then they're working as a team, right? So bringing their expertise together to build that capacity. So really powerful, looking at bringing access to healthy foods to the neighborhood, walking groups, social connection opportunities. So anyways, I could go on and on all night long about all the incredible work they're doing, but huge focus there. But our key is, how do we connect that back to bigger transformation, right? That neighborhood work is beautiful, but how do we get that back to the policy systems piece? So we have a policy committee that is part of our collaborative, and so we're looking at what are those policy issues that we want to tackle. We always, every year, have a local policy agenda. We weigh in on state policy. And we're looking at organizational policy. Our community health workers sit at the decision making with our executive directors from housing, education, the faith community, healthcare. So that's a little bit more detail about the communities that we're serving. But we do work across 4 counties and feel that a lot of our policy systems work that we embark in does have an impact across our 4-county area. And there was a second part to that question, wasn't there? The issues that we're dealing,
Yes.
the challenges.
Yes.
So I'll try to do this quickly. So for us, there's a couple of really key areas of challenges to accessing healthcare. We have a huge gap in just folks that will accept Medicaid. So we have a lot of people that do not have access to healthcare, and to be seen by a doctor can take weeks upon weeks, and you can imagine how this impacts many, many facets of their life. So that's one critical issue. The other that has really, really come across all of our communities is affordable housing. So we butt up against Portland metro area. They're in an affordable housing crisis, and it is definitely started to impact Southwest Washington, all the way into our more rural communities. So we have a huge access to affordable housing. We have incredibly low inventory, rental inventory, and it's causing severe homelessness issues. And so I'm sure you can imagine how this is also deeply impacting healthcare and people's ability to access healthcare and take their medications and get to the doctor and all of those other pieces.
I don't know how you're going to remember all of the differences between our organizations, because there's actually more similarities. So our organization started in the International District historically by Filipino and Chinese activists who saw a need for healthcare access that was both culturally and linguistically available. And since that time, we've really evolved to serve as the nature of the immigration patterns and refugee patterns in the Puget Sound have continued to diversify. Our organization has continued to diversify. And we sort of maintain this ethic of our core mission is to ensure linguistically appropriate and culturally appropriate health care. And but not everybody we serve is a refugee or immigrant, but the definition of a federally qualified health center requires us to have our doors open to anybody and everybody who needs to have access to health care, regardless of their inability to pay, their insurance status, whether or not they're documented or undocumented, or any other status that you might consider for which people might be denied health care. And as part of that, we continue to, but we still serve a significant limited English proficient population. It's currently about 60% of our patients report English as their second or learning language. And then we have, I should also kind of provide some scope. So in the, we have data for 2015. We served approximately 25,000 unduplicated patients. And it's, I would say each clinic, depending on where it's located, has a somewhat unique identity and a unique flavor, and it reflects the neighborhood that they're located in. But we did choose the locations for our clinics, particularly for the South Seattle and as well as Bellevue and Shoreline, based on community needs assessments, where we were looking at establishing not just, we didn't want to just say, we have a clinic, you should come to us, but we also wanted to assess, well, where are our patients who we should naturally serve living? And where should we go? And so we had a long-term plan to expand to the east side as well as to the north end, and we continue to want to go south. in King County, but because we were tracking from the census data where our immigrant and refugee and Asian and Pacific Islander populations living. We also have a sliding fee scale so that people's who remain uninsured are able to access healthcare based on their ability to pay, and it's driven by their family income and family size. And so as an example, if you're 100% of federal poverty level, your bill for medical services would slide to 0, and we ask you to pay a $25 office visit fee. And if that's still too much of a hardship, we could waive that as well. But it is a federal requirement that we at least ask, just to have some sort of cost sharing in the capacity. We do receive a significant amount of both federal as well as local and private foundation funding to serve the uninsured, but we still need, and we also take third-party reimbursements. So we have a significant patient population on Medicaid, as well as Medicare, but then all of the other qualified health plans. What's unique about ICHS among federally qualified health centers is that we do serve a large percent of patients who are enrolled in qualified health plans. They may be income eligible for Medicaid, but because of the 5-year bar for being a legal permanent resident, before you're eligible for Medicaid, many of them are here too short of a time, so that they are, in order to avoid the tax penalty, required to enroll in a QHP. And so across the state, most community health centers enroll probably 95 to 99% of their patients in some sort of form of Medicaid. ICHS, when we do outreach and enrollment, it's about 60% Medicaid and about 40% QHPs. And I think what's also significant is that, and we were in relation to access and insurance status, since the Affordable Care Act, our uninsured rate went from about 30% to about 10%. And we'll always have a little bit of people who are in that churn of uninsured, lost a job, lost their insurance, kind of waiting in that status. And then some people will remain uneligible or unable to afford a QHP and opt to pay the penalty. So that kind of gives you a sense of who we're serving. And then I think I started to sort of track, like, what are the similarities? I guess transportation is, of course, a challenge for patients for accessing healthcare. I put culture and beliefs, and I think part of that is just we spent a lot of time trying to educate our patients on the value of having a relationship with a primary care provider and not waiting until it hurts so bad that you need to go to the emergency room, and really trying to understand that we have, even for our patients who are insured, our community health workers, we have a robust team of 11, report back that patients have this belief as, well, I don't want to go see the doctor because I want to save that position for somebody else who needs it, even though we're trying to say we need to know how to actually serve you if we don't know what you have or don't have. There's a huge, and this is not news to you, but the immigration stigma that our country is going through right now clearly impacts people's interest and or sense of safety to access healthcare. And I think, of course, language is one of our fortes, and then, of course, housing and food security. What we've learned about our patient population is that many of them that we consider housing insecure are living in what's called a doubled up situation, or sometimes tripled up. So there's multi-generations of a family living in a one-bedroom apartment, and really, so they are stably housed, but it's not housing that is actually conducive to human living in a long-term situation. And I think the things that we need to know more about our patients is we're not, because we don't often collect some of the social determinants of health issues. We know some of our patients do have employment concerns, but they also, some of them have multiple employments. And so the barrier of access is managing work and time and the need to see a doctor. And then, of course, the issue of education and being able to, we don't know what kinds of education our patients have, and that actually would be helpful to start tracking, so that because education and literacy in any language has a far more of an impact on health outcomes than actually seeing the doctor. So we would think that that would be helpful to us, for us to think or to ask about.
Thank you, Michael. Did we already? Yeah.
Okay. So overall at the Fred Hutch Cancer Center, which has actually been around 40 years now this year in Seattle, so that's a big celebration. But it's not just cancer that we work on. We actually work on infectious disease. We have a very large division that works on HIV. I myself work with diabetes as well as pesticides in addition to cancer. So we cover all of those topics. And we not only work in the basic sciences, but social sciences as well as economic and policy level aspects. So the institution as itself runs the gamut, trying to cover all levels that affect social determinants of health. My work is actually based on a program that was started nearly 18 years ago in Central Washington by Dr. Betty Thompson, who's my primary mentor. She's a senior researcher at the Fred Hutch. And she, actually, it's a very interesting story. She met some students, and by training as a sociologist, and was very interested in addressing health disparities, and talked to these students about how we could start work out in Central Washington, so lower Yakima Valley, extremely rural area, a lot of agriculture, and a very high percentage of Latinos working in that community. And they took, they started conversations with people in the community and started to find out who the stakeholders were, who the people were that are important to know, who are the change makers in the community. And the strategy that was implemented is called community-based participatory research, which means getting community members involved in every level of the research process. So everything from identifying the question, designing the study, interpreting the data, disseminating the data, and trying to look at how you create sustainability of programs. Because one of the things we focus on is if we're going to develop a program or try to address some sort of disparity or inequity, we don't want it to be a program that's going to go away when the research is done. So that's one of the things that we focus on. Since those two students started working with her, we now have 8 full-time staff that are based in Central Washington. We have a satellite office in that area and have run, she's probably run about 20 studies altogether, not to mention all of the student projects and junior faculty projects that have run through there as well. We have a 24-member community advisory board that we run all of the project ideas by. Even if a student has a concept that they want to present, they bring that to the community advisory board and get their approval. And we talk to them about the methods and answer their questions before we move on with the project. They're very involved. And our work actually extends beyond just the research. We do things like trying to run coat drives and food drives and helping out at the food banks and such, really becoming part of the community. Definitely do not want that stigma of the researcher who conducts research on a community as opposed to with the community. And we really try at every sense to bring the community aboard. One of the primary projects that I started in that area actually came out of a community request, which was to find community support for cancer survivors. There are no Spanish language programs, despite 70% of the population being Latino. There are no Spanish language programs in Central Washington, and we found out there's actually none here in the Puget Sound region as well, which was surprising. So we started with qualitative work, which is asking what are the needs of the community, what are the resources, doing an assessment. And then from that, I developed a 10-week social support group that is adapted both, linguistically and culturally. And we ran that program as a pilot project out in Central Washington, and it went very, very well. We actually found some results. I wanted to say one of the things that I focus on is not the social determinants of health in the more traditional sense. I actually focus on the psychosocial aspect and the aspects of trust and social support and how those play into our health and our ability to access health care, willingness to access health care. How belief systems play into this. So these are all things that we address in the support group and try to bring a appropriate cultural perspective to each of those groups. We've since started running those groups here in the Seattle area, running them all the way down towards Tacoma and up in, let's see, Snohomish County, and Jose here. I didn't know he was going to be here. He's actually one of our facilitators for the support groups. We always use lay health workers to run the groups. So I actually don't interact with the community very often because we have people who are much more qualified than me to run the groups. I give them the instruction. They go through nearly 50 hours of training. They're already very well trained lay health workers, but we did about 50 hours on how to run a support group in particular. And then they run the groups, and we have someone else who does the research aspect. So their main focus is the psychosocial aspect and making sure that the individuals get the education that they desire as well as the social support. Beyond that, I also work with the Native American community. We just did an adaptation with Deidre Buchwald's group at the University of Washington, where they took my Spanish language support group and adapted it for the Native American community, and that was an incredible process. We actually brought in people from New York, Montana, Alaska, and representatives from the Puget Sound region, and just discussing the differences, those regional differences. Even though it had been adapted for Native Americans, the regional differences were incredible. And it's not just images, it's how you talk about things. It's what kind of symbolism you use and how deeply people feel connected to those symbolisms. So we actually just completed that data testing in those regions, and I haven't seen the data yet, but I'm really excited to do that soon. And the other area that I've worked in and was really what I had built working with the community was working with the African American community here in Seattle, and in particular with cancer survivors. And that was very different than working in Central Washington and having a set group of people that were already established and trying to figure out what they were interested in and how they wanted to go about doing the research. With this group, we actually talked. I found out who the primary stakeholders were and who people of influence were that the community trusted, and spent about a year just talking to them about what they viewed were the needs of the African American survivor community here in Seattle. And they helped me develop the question. So very literally, we were looking at the transition from active treatment of cancer to post-treatment survivorship, because there can be almost PTSD in some ways, where people are so focused on the cancer treatment and getting through the technical aspect, if you will, that it's not until after they've completed treatment that there's this realization, oh my gosh, what have I just gone through? It's kind of like when you're in an emergency state. You take care of the emergency, and afterward you're impacted emotionally. And also the fact that the effects of cancer treatment can last for up to 15, 20 years sometimes. So the emotional impact of that, and just getting people ready for how do you address these issues. So we did a qualitative study looking at the cancer survivor perspective as well as the oncology professionals' perspective on that, and found very interesting overlaps and what appeared to be contradictions, but we actually think are things that we can address to try and improve communication within the system. And assist the African American community in some way. So we're actually trying to figure out what an intervention would look like following that. We also have a couple projects that are similar to my support group, one in diabetes, and we're starting another project which actually is the third round, so they've been doing this for 15 years with pesticide exposures in the valley. And one of the most interesting things is the last thing I'll say. One of the most interesting things about that project is that it established the pesticide pathway, that farm workers bring the pesticides from the fields to their home, and showed that there was exposure to the pesticides, metabolites actually present in children's urine from playing on the floor. So that was a very important pathway that was established. What's the greatest thing about that is that the researchers wanted to look at the fields exposure as well as dust in the home. And it was a community member that said, why don't you look at our cars and measure the dust in our cars? And that piece was so critical to establishing the pesticide pathway. So, we may be researchers and have PhDs and all that, but in my world, that doesn't mean very much because the community knows what is needed. The community knows how things are going to work in their environment, how things function socially, politically, economically, and we need their input to make our programs more effective. So that's it.
Last but not least. So the populations that I serve, I'm at Harborview Medical Center, and if you're all local, you know that Harborview is the King County hospital of the area and a level 1 trauma center. And
The only one.
Excuse me?
The only level 1 trauma center in the 5-state Pacific Northwest region.
The only one, yes. We serve immigrant and refugee refugees. And in 1994, this program, Community House Calls, was born out of a Robert Wood Johnson grant from 2 physicians at Harborview. And 2 years later, it became part of the mission of Harborview, because the mission is to serve the most vulnerable, of which that includes immigrant and refugee communities. And so we've continued to serve, and Harborview has taken on that financial role to provide this program. And 3 years ago, we added on a piece of diabetic navigation where we are working with the Somali and the Latino community on self-management. And so really the goal of, or the mission of Community House Calls is to work with the families, the patients, and the communities to partner in providing culturally sensitive healthcare. And the conceptual model is that we're really using the caseworker cultural mediators. That's what we call our staff. You've heard community health worker, patient navigators, similar, although I do have to say that I think that the caseworker cultural mediators at Harborview have a lot of very skilled training, because they serve both outpatients and inpatients in the hospital. And so the conceptual model is really to strive to bridge the gap, to bridge the immigrant and refugees, patients and families, and the community with the healthcare members at Harborview, and then also to bridge the communities with the hospital itself, and really hold the hospital accountable for the dialogue that we have. Some of the challenges for the populations, the immigrant and refugee populations, have been mentioned from the other panelists, but let me just talk about those. The language and literacy of limited English proficient patients is clearly a challenge that we have. Cultural differences and how those work with the Western medical model is something that is a challenge. Past trauma is something that we see a lot with the immigrant and refugees, and is a challenge as well. the age. The majority of the patients that we see in the outpatient area are over 50 years old, so we're seeing very complex comorbidities with the populations there. And then also with that is sort of a generational issue, so you have many of the patients that we're seeing that are the immigrant and refugees, their children may have been really young when they came here or they were born here, and so there are differences around the perceptions, the needs, and the requests from parent to child. Transportation is an issue. What we're finding, in 1994 when this program started, the patients that we served were much closer to the Harborview hub, and as affordable housing has changed that, we're seeing the migration further south, which really impacts transportation. Affordable housing was another one that was mentioned as well.
Thank you very much, Leanne. Already we have, without even getting further into more nuanced questions, we're finding that social determinants of health can be just even at Harborview Medical Center. King County is the third most linguistically diverse county in the country after New York and Los Angeles. Harborview, being the level 1 trauma center in the region, serves these populations. And we see, and all the cases that you've been mentioning, I've seen this, my colleagues have seen this play out at Harborview. Can I ask you, if you haven't already touched on it yet, or to go in a little bit further, does the work that you do address, in overcoming the challenges that your populations face, is your approach focused on looking at the causes and trying to preempt them, or addressing the consequences? So is the work that you do facing upstream, or is it facing downstream? Could you lightly touch on that if you haven't already, or elaborate perhaps?
Well, for us, it's both upstream and downstream. I think that's where we really get to the long-term sustainability, creating healthier communities, is when we're looking at both the upstream and downstream. As I mentioned, policy systems work is critical for us. So that looks at every level. So let me give a quick example around affordable housing. We worked with the Housing Authority. They're a key partner. They sit on our leadership. They saw us as a collaborative that was deeply connected to the community. So they went to us and asked us to help assess the community need on how to prioritize the Section 8 vouchers, which is an incredible resource for many communities, as you know. So that's one way that we can impact how an organization changes how they provide services. And then locally, we're looking at local policy issues. So right now, we're working really hard on an affordable housing campaign in Vancouver. It's new for us to be actually endorsing a campaign and donating to a campaign, but we're really proud of it. And we're doing it because our community health workers said, this is where we start. We can't even talk about access to healthy foods. We can't talk about access to care if we do not have a safe and stable home. And that goes to the same level when we look at our state agenda. So when we look at selecting our state agenda, affordable housing was key. It was number one. We were weighing in on multiple issues, and I anticipate it will look the same in the coming session. So that's where I see kind of that long-term sustainability. And then I just have to always go back to our community health workers, because everyone touched on it up here. Truly, just every day I learn from our community health workers. It is just an honor to learn and work with them. And what's been incredibly exciting is to see our community partners start to value that. So let's stop doing to communities and let's work with, because they have a lot of answers, a lot of solutions, and we're gonna get to much better solutions, and we're gonna know which policies we need to be weighing in on or not. So I'll leave it at that.
I think I have the same answer. I'm just going to provide a little bit of a nuance to it. So I do think it's both upstream and downstream. And I think with downstream, I think we're just some simple examples, and where it's not unique to ICHS. I know other federally qualified health centers are doing this. But to address the transportation concerns, we do participate in helping our patients enroll in the ORCA Lift program. So it's getting them reduced fare based on their Medicaid eligibility, so that if we're able to enroll somebody for healthcare and we know they're Medicaid eligible, then we know they're eligible for ORCA Lift, and we can just sort of streamline that application process for them. So it's a very not necessarily simple, because I know workflows are required, but it's able to sort of like point of care intervention, like you know you're eligible for a service that we think will be helpful, and we can get you enrolled if you're interested. I think, and we also have a community health worker program, so I'm not going to touch on that, because I think the value of those programs has already been very eloquently stated by Kachina. So I think where I think we're finding ourselves is just needing to be a little bit more creative. And the best way I can do this is to tell a story. And so, like, recently we had a provider who sent an email to my colleague, the chief operating officer, and myself, and the CEO, and basically said, I had a patient come in today. She hadn't eaten for 48 hours, and we were trying to talk to her about managing her diabetes. I went to the office and I printed all these things off the computer about the available food banks in the Seattle, King County area, and I scrambled around my office for some nuts and some goldfish from my personal stash to give to my patient. What do you think about having food available for our patients? And we were like, good idea. And then it was sort of like, well, we don't need to be a food bank, so let's partner with people who are in the business of being a food bank. And so we went to one of our community partners, Asian Counseling Referral Service, who runs food banks with culturally appropriate foods, and we said, hey, what do you think about us having just like a bag or two in each of our clinics, so that when a patient needs it, we can give it to them. They're like, great idea. And so it's like those things that, if you just stop and think about what you can do, it's sometimes very simple interventions, but are very meaningful for helping patients get the service they need. Because, like I said, health happens outside of the four walls of that exam room, and health choices are made outside of those exam rooms that are impacted by social determinants of health. The other piece that I think is exciting for me, and I get very passionate about it, is through a private donor and through other networks across King County, ICHS has been partnering to enlist our community members as well as our patients in a civic engagement program, and that includes voter registration and voter education, as well as voter engagement, so like get out the vote efforts. Now, we know we serve patients that some are not legally able to be citizens yet, or have not decided if that's the right thing for them yet. But we also know that whether you're a citizen or not, whether you're documented or not, many people are employed, tax-paying residents. Some of them have children in schools, and so our message is, regardless of where you are in your ability or capacity or interest in being a registered voter, you do have a role and a responsibility, and if you're interested, in being actively engaged and going to school board meetings, writing letters to the elected officials, whether or not you voted for them or not, or can vote for them or not. You have an opportunity to share your opinion, because it's through the community work that they do where they can learn to address their own social determinants of health, like addressing the policies that affect where they live, learn, work, play, and pray. And I think that that's such an important piece. And then if they are eligible, we're able to support them in getting registered to vote, and then also making sure that they're aware that, at least in King County, there are, I think now, 4 languages, because they've added Chinese and Korean to the ballot options. So like helping them understand what resources they have at their avail. And then I'll leave for upstream, I guess. The short story is social determinants of health has really been and impacted ICHS on an organizational-wide level through our board of directors and a strategic plan that was to address the next 25 years. It is very bold to do a strategic plan for 25 years, so it's much more of like a visionary statement. But in the past, our board of directors has been very focused on health care and looking at health care and what we can do, what their role was in providing health care. But when you brought in that conversation to the social determinants of health, and we did a lot of education with our board of directors, you can begin to help them see that the dots between housing security and food security and immigration policy are all connected to health care. And so it kind of, once they were able to buy into a strategic plan that embraced that the fact that ICHS has a role as a community health center in playing in the social determinant of health space and the social justice space, it freed up our capacity on a staff level then to say we recommend taking positions on this policy affecting immigration reform, or we recommend taking a position on this policy affecting housing affordability. Whereas in the past, we couldn't even have those conversations because our board was like, nope, you're healthcare. And so now we've been able, through teaching and learning and conversations and dialogue, and having adopting that in our strategic plan, able to like really shift our work and how we are planning to do that in the future. And so to make that alive, we've been sort of taking that learning down to our management level and down to our all staff level, so that there's a growing awareness that how the social determinants of health are so important in understanding what our patients are experiencing and also what their outcomes are. And then I think the other piece of that then is just, playing a part of those conversations that happen on the state level. I think with the, I don't know how to describe it, but with the healthcare transformation and innovation that's going on through the accountable communities of health, there's a number of venues, both at county level and at regional levels throughout the state, to have conversations. But virtually every accountable community of health network, King County is its own, but virtually every one of them has identified the social determinants of health as top priority. And so I think that both our CEO and myself sit on various committees. It sounds so boring, but we're trying to sort of shift that dialogue and shift that conversation and making sure that our organizations are represented in that conversation. So, thanks.
Okay. Traditionally, I think just because of the way research works, a lot of our work has focused on the individual and family level, so interpersonal levels. Our promotoras do a lot more than the research, or they're required to do. Beyond our research, they're always answering questions for the community, trying to find resources. And we've created, through our community advisory board, really a network of resources for the community, and the community is aware that we are able to help with other things beyond what the research subscribes in some ways. So on those two levels, I think we work downstream, but we are really trying to focus now on including upstream and conducting multi-level research. So our goal is not just to change individual behavior, how do we change a community's behavior? So if you think of things like seatbelt laws or smoking on planes, now there's been a cultural shift in how we perceive those changes. I spoke in a class recently and was telling them about growing up in the 70s in the back of a Chevy station wagon, sliding around in the back, no seatbelt or anything. And I said, what would you think if you saw someone with a child in the back doing that now? And they were like, oh, call CPS, you know, this is horrible. And that was an example of how we've had this cultural shift in our perception. And that's something that we're trying to do now by getting organizations involved, asking restaurants, if we're talking about nutrition, restaurants, the local corner stores, people at Walmart, you know, to post some education for us or allow us to do some education at those places, to talk to them about policies that they have or the physical environment and how we might change that, as well as one of our goals, which we haven't started yet, but we're going to be engaging in, is trying to do some education about civic engagement and how people can become involved in that policy level process. There's a lot of things to consider when you're working with a population that has the issues of documented and undocumented individuals, even in the family, even if they're not themselves undocumented, they have family members that can be something of concern. So there's a lot of issues that you need to address and adapt away from a traditional program. And so we're still trying to figure out some of those issues. But the ultimate goal is really to be all-inclusive. And the health issues that our community face are just so immense in a lot of ways. The percent of people with diabetes and cardiovascular disease in Central Washington is really profound. So I think it's going to take multi-level research in order to make a major impact in the community's health.
So I want to just agree with the other panelists around the value of community health workers, or in our organization, caseworker cultural mediators and diabetic navigators. And I have two in the audience, so I just want to take a moment to acknowledge them. And Jose Mayorga, who's been a caseworker cultural mediator for quite some time at Harborview, and Selma Musa as well. So I'm really grateful that you're here to hear the value that you have from all of these fellow panelists to the work that we do for social determinants of health. So thank you. I think as an organization, Harborview, primarily we're working downstream, and I'm going to talk a little bit about some of the things we're doing at Harborview and then move a little bit upstream. First, Community House Calls has been in existence since '94, and then 3 years ago we got funding to look at diabetes self-management, and Selma Musa works in the Somali community, and that has been quite a very successful program, and helps those immigrants and refugees around self-management of, as Rachel said, a chronic disease that is really plaguing the communities, and really helping them to understand the whole concept of chronic disease, which is new, and I'll talk a little bit more about that later on. The other things we're doing in terms of downstream, we are working on another issue that we find is the whole medication refill issue for our patients, and so we've worked and collaborated with our pharmacy to have a dedicated line for limited English proficient patients so that it can be easier for them to order their own medications and empower them in that way. We also streamlined the financial assistance program. So at Harborview, we used to call it charity care, and we have changed that to call it financial assistance. And with all of our affiliates, there was a different process that patients had to use. And so what a great idea, but let's make it all one application and have it the same. So we've completed that. We have, as you know, in the research, limited English proficient patients have much less time with the medical staff at the bedside in terms of updating them on information. So the staff advocates for the patients and families to have more time with the healthcare team at the bedside, whether that be one-to-ones during the rounds or organized family conferences. Improved transportation, Michael talked about that. We have encouraged and support and advocate for patients to do Orca Lift. We have HopeLink if they're financially eligible for taxis to pick them up, to take them to and from their appointments, as well as Metro and Access. One of the other things that was a downstream example is in the Somali community, we were hearing from a lot of the women patients that they had a lot of headaches and pain and discomfort and fatigue. And so my predecessor, Bria Tchaikovsky-Louis, developed, and it continues, along with Sama Musa, a weekly wellness group that's open to the community for Somali women called Darial, which means wellness in Somali. So it's an opportunity for women to get together, do yoga, have massage, and most importantly, socialize. So that's something else that's been very successful. Some more upstream efforts. One of the things that we require all of our caseworker, cultural mediator, and diabetic navigators to do is to have set aside time for the community work. And so that time is allocated to address issues that they have facing their communities. So for example, we partner with ACRS, and one of our caseworker cultural mediators does a weekly Vietnamese senior gathering where they have over 90 seniors every week on Fridays, and they get together, socialize, they have lunch, they have a health education topic. Or we have Jen in the Khmer community who does a monthly health forum for the Cambodian community, of which they've identified what's important for them. We are also going to be meeting with our social work department to start a pilot looking at improving connections to patients with community-based health resources, so stay tuned for that. And we've partnered, the diabetic program has partnered with the state and federal government around the WIC program and getting monies for farmers markets so that our diabetic patients can go and purchase at the farmers market healthy vegetable and fruit choices.
Thank you very much, Leanne. I want to just make note of the time, and we also want to allow our audience members to interact with our panelists afterwards and have some networking and socializing. I'd like to maybe open it up now to Q&A from the audience, and may I do that by priming with a couple of other comments and questions that I'll just stop with that. Upstream and downstream are all related, and what comes upstream goes downstream, and Leanne, you were I'm sorry, not Kachina. You were saying that how can someone say, well, before I start thinking where do I get healthy food and how do I start making equitable health choices if I don't have access to healthy affordable housing. Rachel, you were saying that in the case of the migrant workers, the pesticides were found in the urine, right? That is a case where a behavioral, something that's community and behavioral becomes a biological determinant of health, right? So these things are really sequential and so connected. What kind of collaboration with our local stakeholders here in Seattle is possible that doesn't yet take place? And we have such a rich diversity of stakeholders, the School of Medicine and the Gates Foundation and PATH and Intellectual Ventures and Vulcan, Paul Allen's Vulcan. There must be some kind of collaboration that doesn't yet take place that, Michael, you said creativity, Let's be creative. Let's offer food to our patients. Leanne, you mentioned the pilot programs that are taking place right now. I mean, sometimes you don't need to reinvent the wheel. So I'd like to just open it up to questions from the audience, and please engage.
And if you could just give me a second to give you a mic to the people who are online and recording, and also.
I'm wondering how well are the mental health needs being addressed, either through your lay health workers, but specifically folks who have more needs than a lay health worker or lay community member can address?
So my experience in observing at Harborview with the staff and the system there is that it's relationships with the mental health clinic that we have, and the stigma that's involved. And so what I have seen is that the community health the caseworker cultural mediators will meet with the patient, sort of advocate and broker around the stigma and what that means, and then developing a trusting relationship. I mean, I think one of the things that I've learned, and we've learned from the communities, is relationships matter. I know that seems really simplistic, but I think that's really important, and I know Rachel mentioned too that whole notion of trust, and so that's what the caseworker cultural mediators bring, is that element of trust to get folks into the system. One of the things that we're doing with the mental health folks at Harborview is with the Ethiopian Amharic speakers, is that the caseworker cultural mediator is there with the therapist, and they have organized what they're calling for that community tea time, because the tea ceremony is really important for that community, and that's the opportunity to come together and talk about the mental health issues that are going on, and to gather around something that's a common cultural practice. So that's one example. I don't know if that answers your question completely, or if there's anybody else.
I'm also just curious about access. Can they get timely access?
Yeah, so that's what I was going to say. So part of, I think this is true for all federally qualified health centers. There's a movement to have what's called integrated behavioral health care that's on site. So we have more than one, but I don't know the actual FTE ratio at each of our clinic sites, including the school-based health center, that are either licensed psychologists or licensed mental health therapists or licensed clinical social workers. And then we are moving towards a model where we're also hiring more of like a master's level medical social worker to assist with some of the a lot of times the barriers our patients have are just the forms. There are so many forms. And so just needing to help them navigate the systems that they need, the application processes. But so there is real-time access. We actually value the opportunity to do what's called a warm handoff. So if a primary care provider determines that a patient might benefit from a conversation with a behavioral health person, it's a lot easier to say, hey, Randon's going to stop in and introduce himself and get to know you and talk a little bit about, how you're doing. And then that could be followed up with an appointment with Randon so that they can continue that conversation if they're not able to stay for that same day. Because oftentimes patients don't come expecting to see two different providers. So it's just trying to navigate that for the patient's perspective as well.
If you've got someone on site, though, how many languages are they effectively able to speak?
Yeah, so I mean, in addition to having bilingual staff, we have a position it's kind of similar but different from what Harborview has. It's called a health assistant, and they're hired to be medically certified interpreters, and they assist the conversation because there's no way all of our staff can speak all the languages that our patients do. And then if we're not able to, we also utilize resources that are available to us. So Medicaid still pays for a medical interpreter. So if a patient has Medicaid, we will use that option. And then we have other opportunities to use what's called In Demand, which is a private company, but they provide basically Skype-based interpretation. And then if a video interpreter is not available, it automatically flips over to a phone call that can be interpreted. It's interesting. It's actually, patients have very different experiences with it. Some actually really value the opportunity for a video interpretation or a telephone interpretation, because when you, particularly with mental health, you get into some of these smaller communities where everybody knows everybody. Like if you're a Karen speaker, you pretty much know all of the community. And so like if you're trying to have a confidential mental health appointment, it's much easier if somebody is coming to you from outside of the immediate local community to have that interpreted experience. So I think that we do use technology to enhance language access so that we can meet those needs. I think the other piece, and I thought about it when you asked your question and when Leanne was talking, what we've also had to be attentive to is that, we employ people from the community, and many of them were also refugees and immigrants themselves and experienced the same things that our patients might be also needing to process. And so many of them, there might be a patient who, survived the killing fields in Cambodia, and we have a Cambodian interpreter who's kind of then experiencing that. And we've had to really pay attention to the concept of secondary trauma and like really paying attention to, are we supporting our staff enough so that they can do these difficult interpreted visits regarding behavioral health issues?
If I could add really quickly, you asked about working with the lay individuals, and that's a lot of the training that we did was, where is that line? We worked very hard. We worked with a licensed clinical social worker who had worked with promotores before in North Carolina to make sure that they not only had a resource that they could go talk to personally for the emotional impact of the group, but also if they had questions or concerns about someone, there's one Spanish language behavioral intervention person who works in mental health as well in Central Washington area, the area that we work in. There's one, yes. And we had a direct line with him so that patients could be referred, and had a chaplain online as well. And our promotores offered to help with if there was something immediate, because sometimes during the groups when people start to open up, things come out, and a lot of domestic violence, suicide ideation, things like that came out. So we had a system in place to help support both the promotoras as well as the patient. And it's a little difficult when you're not in an actual medical setting, but we did the best we could with that.
Yeah, I used to work for a nonprofit called Health Leads, which you may be familiar with, that their model is to staff a help desk in the provider setting with volunteers that then help refer patients to community resources, help them fill out the forms, things like that. They made the tough decision a couple of years ago to stop following up on referrals for housing, because the success rates were just so low that we just kind of gave up. At the same time, we realized that that's one of the largest indicators of future health. So how do you sort of balance the trade-off between handing a bag of food, which you can do every time, versus trying to fight for housing for somebody, which has a much bigger impact on their lives, but you feel like you're beating your head against a wall a lot. How do you guys think through where to spend your resources?
Sure, I'm just holding the mic.
So that's where I think the collaboration piece comes in. For us, we are all about our partners. We are nothing without our organizational partners. So it's getting down to, how do we plan together, right? How do we make those hard decisions as a community? So one of the things that we are launching right now. It's in the works. As healthcare transformation happens and as we're starting to do work differently, there's data needs, and that's a key piece. We always want to look at evidence and the data to help guide our choices. So right now, Washington State and the Healthcare Authority are looking at an analysis that looks at claims data. We're saying that's important, but we also want to look at housing data. We want to look at education data. We want to look at criminal justice data because we think they're all linked. So we're in the process of looking at those shared data agreements and how we plan together. And a key piece of that will always be the key core information from our community health workers to what is happening in the community, what's not happening in the community. So that will be a hard piece of, and I think someone was going to talk about the prepare.
Yeah,
maybe I should hand it off to you.
Since she's already led me into it. So I just got back from the National Association of Community Health Centers conference, and ICHS is a member of that organization, as well as APCHO, which is this Association for Asian Pacific Community Health Organizations. Just want to give them credit. They've been a leader in an effort to develop a standardized protocol for collecting social determinant of health data from patient populations. And the reason I got excited about it is because we all know this stuff intuitively and we hear the stories, and stories are compelling, but sometimes data is needed in order to get resources and to help you prioritize. And for me, what I think about, so PREPARE stands for the protocol for responding to and assessing patients, assets, risks, and experiences. Whew, I got it right. But the PREPARE model is intended to standardize that. And what excited me about it is that it is getting traction nationally among federally qualified health centers. And I think that, I don't want to put the cart before the horse, but I know that ICHS is assessing our capacity to do this and to be a part of that. Because what I see happening is that in true place-based social determinant of health-driven healthcare transformation and delivery systems, what social determinant of health we address in our Chinatown International District clinic might be different than what social determinant of health data is coming out of our Shoreline clinic. And so we would want to be flexible enough as an organization to not say, well, this is the social determinant of health issue we're going to address, but to understand that, well, our data says this intervention's needed here, but a different intervention is needed somewhere else, and we should be able to respond to that need. And then I think the other piece that's exciting about this is that, and if we think about partnerships, the ability to then share that data after it's collected, if everyone's collecting it in the same way, then we have comparable data. And federally qualified health centers are accustomed to this because we participate in something that's called the Uniform Data System, where we all collect the same data that's sent to the federal government, that so that if we were all doing this around social determinants of health and we serve across the country a safety net population that is very unique, and if we could tell their story and understand the differences and the nuances from, even from county to county or city to city or state to state, I think it's going to be very helpful in identifying where should we put our resources. And I think the easiest thing for us to do probably is, I'm sure that Cambia Grove has contact information for some of for the participants, because I could send out a link rather than try to tell you one today. But I mean, the NAC website has a very comprehensive summary of the PREPARE project, and the social determinants of health across the country and through NAC and federally qualified health centers was a key and core component of the messaging at their conference. And so I think the time is now to figure out how do we do that, and with the partnerships as well, as we need to be able to have this ability to collect the data across multiple electronic health record platforms, and that's not an easy thing when you're an FQHC. We know our electronic health record, but we don't know anybody else's. And so that's where we need some of those innovators around technology folks who understand how can we create these templates so that they can speak to each other and the data can be shared and we can sort of tell the story.
David, how many more questions do we have time for?
We have time for, I think, one more question, or maybe two in the front.
She's had her hand up.
Yeah.
Hi, my name is Ira Sengupta, and I'm the Executive Director of the Cross-Cultural Healthcare Program, doing this work for 25 years. I am so excited and so thankful to Cambia Grove for bringing together stunning panelists and a great moderator that I have to say I'm a little biased because we work together. But anyway, I have questions for all of you, but there's only one question time for, so I'll be asking those questions. So let me just ask you, is it okay to address you by your first names? Okay, so Kachina, I'll start with you because you were the first panelist. And I was very interested in your description of your community health workers. One question that I have is, so they get a $200 stipend and they're volunteers. Is there have they moved, is there a potential for them to have more professional growth with salaries in the healthcare system that they are now understanding so well?
Thank you for asking that question. Yes, so with little financial resources to get this off the ground, that's where we were able to start, and we're incredibly proud and excited by the work that our community health workers have done. So it's really interesting. I don't know if you've watched and looked at the Salishan community health worker model in Tacoma, but we've modeled much of our work after that. It's in a housing authority setting, and we're looking at in a community setting. So that too is a stipend. But yes, we are seeing huge, our hope is to build out community health worker activities in multi-sector. So the exciting piece, going back to the collaboration component, is our different organizational partners are seeing the value of this. So our federally qualified health clinics are saying, yes, we need more of this. Our education partners are doing the same. We have a permanent supportive housing center that houses 30 of some of our highest need communities. They're saying we need a community health worker. So we have a lot of grants in motion right now, crossing our fingers to build that out, because yes, we need livable wage community health worker jobs. And that is a goal. The stipend volunteer piece is also a beautiful platform for some. We have folks that are retired, and this is their way that they love to give back. We have moms with small children, and this is a way to continue to build their skills and abilities. We've had a number of community health workers go back to school this year. So yes, that is our goal, and I can't wait to say what we're doing in 3 years from now, but we're starting small.
Great. I think I think it's time to Michael. I don't know if you want to answer that question.
I was going to ask a question for each.
But there was only allowance for one.
I see.
So I can still
Okay.
We'll talk later.
Yeah. Well, I think the good thing is that you can hang out here for a little while, have some more food and some more beverage, and talk to all of our wonderful panelists, as well as Samuel, who did a great job moderating. I agree with you, even though you may be biased. And so I want to first of all thank everyone for coming, and then thank our panelists and moderator. And I hope you'll stay for a little while longer and connect among yourselves and have good conversation around some of the topics that we talked about today. So thank you.
Thank you for having us.